Hi, I'm Lisa Zhang, and I'm currently the GI Pathology Fellow at MGH. In this video, we'll be going over the normal histology of the tubular GI tract, and we'll be looking at a combination of mucosal biopsies as well as full-thickness sections from resection specimens. We'll get started at the top of the tubular GI tract with the esophagus. Here, we have a representative mucosal biopsy. Mucosal biopsies are the most common type of specimen that you'll see on the GI service, and they are taken during an endoscopy procedure where the clinician will pluck off a piece of relatively superficial mucosa. So we typically don't even get much of the whole mucosa, we really just see the epithelium. And we'll talk a bit more about the layers of the mucosa in the next section. So the esophagus is lined by a non-keratinizing stratified squamous epithelium. And this is the look of squamous epithelium you can see at various sites within the body, including the skin, but also here in the esophagus. Non-keratinizing means that at the surface here, we don't see that really pink layer of keratinizing squamous cells. And stratified means that we have many layers of cells stacked on top of each other as opposed to a single layer of cells. So if you look a little closer here at the esophagus, this is a pretty normal looking esophagus. All of these layers of nuclei look very small, bland. They look like they're maturing to the top. And you can see that the bottom layers of the epithelium appear a little darker, a little bluer than the rest of the epithelium. And this is called the basal layer. Normally, the basal layer is only up to a few cell layers thick. We can also see vascular papillae that extend from the bottom up into the epithelium. And here's a little one here, here's another one here, and here is the tip of one where we've only caught it at a cross section at this level. And normally, the vascular papillae are confined to the lower 1/3 of the thickness of the epithelium, so you shouldn't see them going all the way up to near the top. Now we come to another part of this biopsy where we see not only the epithelium here, but also this fragment of pinker looking tissue. And you can see that it appears to be separated from the epithelium at this thin pink layer here, which is the basement membrane. But right here, you can see it attached. This is a little piece of lamina propria that we've caught in this section. The lamina propria is the layer beneath the epithelium in the esophagus, and it's composed of loose connective tissues, some collagen, some small blood vessels, some lymphatics in this location, and we can see some degree of chronic inflammation in this layer as well. Next, we'll move a little further down to the gastroesophageal or GE junction. This is where the esophagus transitions into the stomach, and the first part of the stomach is called the cardia. So in this section, we can see that this one, unlike the last one, is a full thickness section of the stomach wall. And on this part here, we can see that stratified squamous epithelium at the top. And as we move along, we can see that it transitions into a different type of epithelium that we'll discuss in a second. I wanted to use this section to go over the four main layers of the wall of the tubular gut. And essentially, the entire tubular gut is composed of these four layers. So the first layer is the mucosa, and the mucosa consists of the epithelium, which is up here, the lamina propria, which is that loose connective tissue layer right beneath it, and then the muscularis mucosa, which is a layer of smooth muscle beneath that. So those three components make up the mucosa. And in the esophagus, the muscularis mucosa is somewhat interesting in that whenever there are reactive processes going on, it tends to get very thickened or duplicate. And so here you can see that the smooth muscle layer of the muscularis mucosa, which are these thin pink sort of linear structures going across the screen this way, actually spans from all the way up here to all the way down here. And beneath the muscularis mucosa, we get into the submucosa. Here's what the submucosa looks like. It again is composed of this loose connective tissue. It has some more collagen. It has larger blood vessels. You can see one here, a few more here. It also has lymphatic spaces, such as this one here, a very thin-walled structure containing this light pink lymph fluid. And then beneath the submucosa, we have the muscularis propria, which is quite a thick layer in the esophagus, because as we're moving food down the esophagus, we need these muscles to engage in peristalsis to move the food down. We have two layers of muscle here, usually an inner circular layer and an outer longitudinal layer. And between those layers, we can see the nerve plexus here. So this is nerve bundles and some ganglion cells, which are these larger cells with very round, large nuclei and abundant eosinophilic cytoplasm. The outermost layer of the tubular gut varies depending on whether that portion of the gut is in the retroperitoneum or whether it's intraperitoneal. So the esophagus is a retroperitoneal organ, and so the outermost layer, which is marked by this black ink here, is called the adventitia. Next, let's take a look at the transition zone between the squamous epithelium and the glandular epithelium of the stomach. So here you can see an abrupt transition between the stratified squamous epithelium and this single layer of columnar mucinous epithelium, also known as foveolar epithelium. This mucinous epithelium secretes mucus to further lubricate the food that is coming down and protect the stomach from autodigestion by acid. Here in the first part of the stomach, also called the gastric cardia, we almost always see some degree of chronic inflammation in the lamina propria. So here the mucosa is composed of the surface epithelial layer, the lamina propria, which is all of this connective tissue and inflammation in between, and then down here again we have our muscularis mucosa. The gastric cardia and the last part of the stomach, the gastric antrum, have similar histologies, and so often we discuss those as one type of gastric epithelium, whereas the gastric body fundus, which takes up about 90% of the stomach and is in charge of the acid secretion, has a separate but uniform histology, and we can take a look at that first. Here we have 3 strips of full thickness gastric body fundus. And again, just to go over our layers, we have the mucosa on top, which is composed of the epithelium, the lamina propria, which is not very prominent in the stomach, but is this loose connective tissue space in between the epithelial cells. We have all of these glands here in the stomach, and then beneath that, this thin layer of muscularis mucosa. Beneath that, we have a thick submucosal layer that has a lot of fat, connective tissue, large blood vessels. Beneath that, we have our 2 layers of muscle, inner circular and outer longitudinal layers. And then the stomach is an intraperitoneal organ. And so instead of adventitia, we can see serosa on the outside, which is a thin layer lined by mesothelial cells. Let's see if we can find any of those cells here. So normal mesothelial cells are very bland, and some of these very thin spindled cells might be mesothelial cells. The serosa is just a very thin outer lining. Let's go back and talk about the mucosa, because that's the most interesting part and the component that we see the most often in stomach biopsies. Here in the gastric body fundic type mucosa, we have a ratio of gastric pits, which are these invaginations of the surface epithelium, to the gastric glands, which is all of this here, typically about 1 to 4 to 5. So again, the surface epithelium, also known as foveolar epithelium, is the simple mucinous columnar cells. Beneath that, we have these very pink cells, and these are the parietal cells, which are responsible for secreting acid and intrinsic factor. They have very small round nuclei with very abundant pink cytoplasm, and there's a greater proportion of them in the superficial layer of the glands. As we get deeper down, we can see a greater proportion of these darker blue purplish cells, and these are the chief cells that are responsible for secreting pepsinogen, another proenzyme that helps in digestion. Another cell type that is a normal constituent of the tubular gut are neuroendocrine cells. They stand out as these round cells with a sort of fried egg appearance or have a white halo around them, such as this cell or this cell here, or this cell here. In the body fundus, these cells are called ECL cells or enterochromaffin-like cells. They secrete histamine, which further helps the stomach secrete more acid to aid in digestion. So this is what gastric body fundic type mucosa looks like, and you may also hear the words oxyntic mucosa, which also refers to this appearance of mucosa. Next, we'll take a look at gastric antral or cardiac type mucosa, which you can see looks quite different from the type of mucosa we just saw. The difference here is that the antral mucosa is composed of purely mucinous glands at all layers of the mucosa. You can see they all look like columnar mucinous cells. We don't see any of the parietal or chief cells that define the gastric body fundic mucosa. Here, the ratio of gastric pits to glands is typically 1:1. We can see the pits coming down here. There's a lot of profiles here because they're cut a bit in cross-section, and then the glands down here. So it's about a 1:1 ratio. We can also see neuroendocrine cells in the antrum as well. For example, this one here that has a little halo around it, this one here, except that the neuroendocrine cells at this location are G cells, or gastrin-secreting cells, and these are neuroendocrine cells that are exclusive to the gastric antrum. Next, let's move on to the duodenum. Here we have a representative full-thickness section of the duodenum. And again, we can see that it looks quite different from the stomach that we just saw. We can appreciate the layers of the bowel at low power, where we have the mucosa up here, the submucosa here, which you can see contains a lot of these glands that we'll discuss in a little bit, the muscularis propria down here, this thick pink layer, and then the outer layer would be the serosa, which sometimes is hard to appreciate on these sections because it's very thin under normal conditions. So let's go back and look at the mucosa. From lower power, we can see that instead of a flat surface with invaginations, also known as pits, in the stomach, we have these finger-like projections called villi. And throughout the small intestine, we have the villi because that increases the surface area with which the small bowel can absorb nutrients. In contrast to the epithelium we saw in the stomach, which was all mucinous, here the cells that comprise the surface epithelium are these columnar pink cells and these interspersed goblet cells here. And these pink cells have a fuzzy border called a brush border. And these are enterocytes with microvilli that further increases the surface area for absorption. One thing to note about the lamina propria of the small intestine onwards into the colon is that there's a lot more inflammation here. And that's just the normal appearance of the small and large bowel. The inflammation should be chronic inflammation, so should be a mixture of lymphocytes and plasma cells, which you can see with these eccentric nuclei and slightly paler pink perinuclear HOF. However, seeing neutrophils is not normal in this location. Now let's turn our attention to these very pale mucinous glands that we saw filling up the submucosa. These are called Brunner's glands, and they are unique to the early parts of the duodenum. And seeing the Brunner's glands really helps us know that we're in the duodenum, especially when we're dealing with a small biopsy. So the Brunner's glands are bland mucinous cells with their nuclei sort of pushed to the edge of the cell, and they secrete this alkaline mucin that helps neutralize the acidic food coming out of the stomach to protect the duodenum. In the small and large intestine, we can also see lymphoid aggregates with relative frequency. Some of them might be reactive and have germinal center, some of them are just normal lymphoid aggregates, and these are normal constituents of the tubular gut as well. Lastly, in the duodenum, I wanted to show an example of normal duodenal biopsies. These are, again, those endoscopic mucosal biopsies where they pinched off a piece of the mucosa. And this is typically what we see, and it's actually a fairly well-oriented section. So we see these villi, these projections into the lumen, and then we see this ball of Brunner's glands here. And so we know that this was taken from the duodenum. And here, this is a nice section because we can see some other types of normal cells in the duodenum. So if you notice these cells with very large reddish granules, these are called Paneth cells, and they are present from the duodenum all the way to the middle of the colon. These secrete antimicrobial substances that help regulate the microbiome of the gut. So you can see these as normal components of the small intestine. Again, we also see neuroendocrine cells, which are these small round cells with this fried egg appearance and this white clearing around them. And then as before, we can see enterocytes and goblet cells, where you can see more of the pale blue texture of the mucin in this section. All right, moving on to jejunum. We rarely see sections from the jejunum, and this one happens to be from a resection. And the thing that I'll just mention is that as we move further down the small intestine, one thing that happens is that the villi get longer. So whereas in the duodenum, we had a villi to crypt ratio of maybe 3 to 1, here we're getting much longer to maybe 4 to 5 to 1. We wouldn't know exactly that we were in the jejunum, other than that we don't see Brunner's glands and the villi seem somewhat long. All right, next we can go over the ileum, ileocecal valve, and then into the cecum, which is the first part of the colon. This is a beautiful full thickness section of the ileocecal valve. Or on the left-hand side here, we have the ileum. You can even see at this low power these blue balls, which are hyperplastic lymphoid follicles, also known as the Peyer's patches in the ileum. We have the actual valve here. You can see the muscularis propria layer coming up here, forming the valve. And the submucosa tends to be very fatty in this region. And then we transition from the villus architecture of the small intestine to the flat crypt-like architecture of the large bowel. So let's look a bit at the ileum. The ileum has even longer villi, and so we see a lot of these floating villi, and that's because they're so long that we just tend to get a lot of it in cross-section when cutting it, and we can't get it all in one profile. Again, we have the Peyer's patches here. In the ileum, we have a lot of Paneth cells, all of these cells with very large reddish granules. And we even have more secretory goblet cells here. So you can see that the proportion of goblet cells to the pink enterocytes has increased. As we move along here to the beginning of the cecum, again, seeing these lymphoid aggregates is totally normal. And as we transition to the cecum, which is the first part of the colon, we can see that the surface is essentially flat. And now in the colon, the epithelium is a single layer of columnar cells, which again includes enterocytes and goblet cells, though with a higher proportion of goblet cells as we move down the colon. And you can see the single layer comes from the surface and all the way down, almost touching the muscularis mucosa. And this is called a colonic crypt. This is often referred to as the test tubes in a rack appearance, as each of these colonic crypts is parallel to one another, and it comes down to almost touch the muscularis mucosa. I also wanted to briefly touch on the appendix, which comes off of the cecum, so this is a good place to do it. You can see from low power that this is one section of appendix. And when we're submitting routine sections of the appendix, we typically cut off the tip of the appendix, bisect it, which are these two profiles here, and then we take some other representative cross sections of the appendix. And whoever submitted this section was very ambitious and managed to fit 5 cross sections in this one cassette. So we can take a look at the appendiceal tip, and all the layers of the appendix are the same as elsewhere in the tubular gut, and it looks just like colonic mucosa, except that we see it in a slightly different orientation because of the way it's cut. So on the inside here, we have the mucosa, which here, a lot of it is cut in cross-section, and so this is called that flowers in a bed appearance of colonic crypts cut in cross-section. We have the lamina propria in between the crypts, which, as in the small intestine, has chronic inflammation. The appendix is a very immunogenic site, and so we can see pretty prominent lymphoid follicles in the appendix. Here's the submucosa, which we can see is pretty fatty in this appendix, and then beneath that, the muscle layers, so the inner circular and outer longitudinal muscularis propria layers. And this section, we can actually see a nice serosal layer on the outside, where the mesothelial cells are a little bit reactive appearing. They look like they're hobnailed here, and that actually allows us to see this serosal lining a little bit better. And then these cross sections of the appendix are the same thing, going from the inside out. In the inside, we have the colonic mucosa, we have muscularis mucosa here, lymphoid aggregates, submucosa with some fat, some collagen, and then our muscle layers, and then the serosa on the outside. All right, now we're going to look at a section from the left colon, and I just want you to appreciate that the proportion of goblet cells to enterocytes has increased again. And if you think about it, when food gets to the left colon, it becomes a lot harder as a lot of water has already been absorbed in the colon. And so we want all these goblet cells to provide more lubrication and help the elimination of feces at this location. The amount of inflammation we see in the lamina propria decreases as we move from the right to the left colon. In addition to lymphocytes, plasma cells, and histiocytes, we can also see admixed eosinophils. However, seeing neutrophils in the lamina propria or the epithelium is not normal. Next, as we move further down, we get to the rectal-anal junction. The rectum is the lowest part of the colon, and so it still has the colonic mucosa, very rich in goblet cells. And then at the anus, we start getting back into squamous type epithelium. So here we have the rectum, and then we see this sharp transition from colonic mucosa to this sort of transitional type mucosa where it's reminiscent of that stratified squamous epithelium we saw in the esophagus, but still has this layer of glandular cells on top. And so this is transitional type mucosa. The basal layers look kind of squamoid, but then on the top we can see these columnar cells with mucin. And so here we're transitioning. On the next section, we which is the anus proper, we are left with just purely stratified squamous epithelium. So we've kind of come full circle, except that in the anus, depending on how close you are to the external anal canal, the squamous epithelium starts to resemble skin more and more until it actually is skin. So here is actually kind of irritated, keratinizing squamous epithelium. We can see the maturing squamous cells and then this granular layer right here with these purplish granules. And then on top of that, we have this really pink layer. When they have nuclei, it's parakeratosis, and then when it doesn't have nuclei, it's hyperkeratosis. And that's just a reactive change that can happen in an area that is frequently irritated. In the anus here, the most common pathology we're trying to evaluate that is of clinical concern is the presence of squamous dysplasia. And so this parallels what we see in the cervix and the vagina. Other pathologies that can be seen here are cutaneous diseases of the skin, and also this is an area where patients can get hemorrhoids. And so when we have very large aggregates of dilated vessels, for example, such as down here, and the patient has the corresponding clinical symptoms, then we can make a diagnosis of hemorrhoids as well. So that concludes our quick journey through the tubular gut from the esophagus all the way down to the anus. And I hope I've covered some normal histology elements that will be helpful for you on your rotation. Good luck and thanks for listening.